Your breasts might kill you. This video might save your life. I got my first bra when I was 11. It was a training bra, and I remember thinking that it felt so odd to call it that, as if it were like learning to ride a bike. Does having boobs really require training? A lot of being a woman seems to, at least when it comes to our bodies, like shaving your legs for the first time, or finding creative ways to hide a tampon. So, does having breasts really require training? Yes. There is the unsettling truth that your breasts might try to kill you. Actually, breast cancer can kill you, not your breasts. Your breasts are great. So, who's at risk for breast cancer? Every single woman is at risk, and a small number of men. You don't need a family history to be at risk. 75% of new breast cancer cases have no family history. You can be a good person and do all the right things, like never smoke, run every morning, eat celery on your lunch break, only drink in moderation, take in every stray animal, remember all your friends' birthdays without the help of Facebook, and still get breast cancer. That's because being a woman is the #1 risk factor for getting breast cancer. I know, this feels like losing some cosmic bad luck lottery. Well, the good news is that even though breast cancer may push us around, we can push back. Breast cancer can grow, which means at some point it's very small. If you find breast cancer early, you have a 95% chance of beating it. If you wait till it's full grown, your chances of beating it drop dramatically. That's why the best thing you can do to beat breast cancer is to find it early. How do you find it? You have to look for it. That means every woman get your mammogram every year starting at 40. Period. Regardless of all the mixed messages out there about when to get screened and how often. Every woman, every year, starting at 40. This is a good starting point because every woman is at risk, but some women are more at risk, which is why it's so important for you to know your personal risk factors like your family history, your genetics, your breast density. 40% of women have dense breasts. Not those kind, these kind. Dense breasts make it much more likely that you will get breast cancer. The tissue looks cloudy on a mammogram, making the cancer hiding inside harder to find, which is why women with dense breasts need extra screenings like an ultrasound. It's not just for babies. There is no one-size-fits-all for breast cancer screening, kind of like how there isn't just one kind of lipstick for every woman. You need a personalized approach. So do you know your risk factors? Are you high risk or average risk? I said this video could save your life. That's not really true either. It's just a video. Early detection can save your life. So right now is the time when you make an appointment. I'm not kidding. Do it right now. Yes, you. Write it down. Set a reminder.
Hey Siri.
Do a painting or tie a knot. Know your risks. Ask for personalized screening. Get your mammogram every year at 40 and share this video with someone you love.
Good evening. I'm Wendy Kurtz, president of the Sisterhood at Beth Tikvah B'nai Jeshurun Synagogue. We partnered with our neighbors and friends at Congregation Orami to bring this discussion to you on the topic of early detection of breast cancer. None of us is immune, and every one of us knows someone who has endured the pain of a malignant diagnosis. But those who caught it early had the most options available to them for treatment, and nearly all of them survived. But the key was finding it early. We coordinated this presentation and discussion tonight because healthcare options for early detection have changed over the past few years, and we want to arm you with the knowledge and tools for communicating with your doctor and your insurance company. Know your risk factors so that you can advocate for yourself. Thank you for prioritizing this discussion tonight. We're confident you'll walk away learning something and feeling more confident about managing your own breast health. If you have questions that you wish for the speakers to cover, Please add them to the Q&A box at the bottom of your screen. We'll be covering the questions at the conclusion of the discussion. Amy, anything to add?
Thank you so much, Wendy. And hello, ladies, and welcome to this important event tonight. I want to first introduce myself for those who do not know me. My name is Amy Seidman. I am the chair of Congregation Orme Sisterhood. And I just want to thank Wendy and the Sisterhood of BTBJ for including us in this important night tonight. It's a pleasure to work with a community and helping women. I also just lastly want to say thank you to the Brem Foundation. What an amazing team that you have. And I say thank you. I hope everyone enjoys themselves, and I thank everyone for joining us tonight.
Okay, so I'm very pleased to introduce Elisa Searman. She is a member of our BTBJ community who will be sharing a personal story to kick us off. Elisa?
Hi, as Wendy said, my name is Elisa Searman, and I am a member of the BTBJ Sisterhood, and I was also on the planning team for tonight's event. I am also a breast cancer survivor. I know the importance of mammograms and early detection, as my breast cancer was found through my annual mammogram combined with a follow-up ultrasound, biopsy, and MRI. I also know the importance of genetic testing and counseling, what it feels like to learn that you have an inherited genetic mutation, the implications of that mutation on yourself and your relatives, and how those results can guide your treatment and surgical decisions, as well as the preventative measures that you need to be taking because of that mutation. I feel very lucky that my breast cancer was caught early at stage 0, which is non-invasive, and that based on the results of my diagnostic tests and my genetic testing, I was able to make an informed choice almost 2 years ago to have a bilateral mastectomy with immediate reconstruction. This surgical treatment was successful in removing all traces of cancer, and I didn't need chemo, radiation, or any hormone blocking drugs. I feel blessed that my breast cancer was caught early and hope that my story reiterates how important it is that women of all ages are as informed as possible about their own breast health and breast cancer risks. Tonight, we're going to hear information and advice from some amazing experts in a conversation with renowned physician Dr. Rachel Brem and genetic counselor Elizabeth Stark. I am pleased to introduce tonight's moderator, Andrea Wolf, who will then introduce our honored speakers. Andrea Wolf is the CEO of the Brem Foundation to Defeat Breast Cancer. In this role, she works to maximize every woman's chances of catching an early curable breast cancer. Since assuming this position in 2015, Andrea has significantly expanded the Brem Foundation's reach. Prior to assuming this role, Andrea served as the Director of Public Policy for Girls, Inc. Before that, she was an attorney at Patton Boggs, LLP. Andrea graduated cum laude from the University of Pennsylvania and got her JD from the George Washington University Law School. Andrea lives in Washington, D.C. with her husband and 4 daughters.
Thank you so much, Elisa. As you said, I'm Andrea. I'm the CEO of the Brem Foundation to Defeat Breast Cancer, and I am honored to be here with you all tonight. I'm also very excited to introduce Dr. Brem. Dr. Brem is the Director of Breast Imaging and Intervention at the George Washington University Medical Center. She's a professor of radiology and the vice chairman of the Department of Radiology. Dr. Brem has served as the Brem Foundation's Chief Medical Officer and inspiration since its inception in 2006. She's a fellow of the American College of Radiology and the Society of Breast Imaging. Dr. Brem is the recipient of countless awards, including Castle Connolly Best Doctors and Best Cancer Doctor in the United States. In 2015, Dr. Brem was ranked as one of the top cancer doctors in the US by Newsweek magazine. In addition, Dr. Brem has been instrumental in developing new technologies for earlier breast cancer detection. She's published over 140 papers and has lectured widely, both nationally and internationally. Dr. Brem received her BA in biology from Brandeis University and graduated with honors from Columbia University Medical School. Dr. Brem completed her diagnostic radiology residency and breast imaging fellowship at the Johns Hopkins Medical Institution. In addition to her clinical and academic accomplishments, Dr. Brem is a zealous advocate for early detection and has dedicated her career to finding effective and innovative ways to increase breast cancer prevention and early detection. For me personally, her most important role is as my mom. It is an honor and a pleasure to be on this journey together with her as a mother-daughter team. Hi, Dr. Brem, Mom.
Hi, Andrea. Hi to the incredible women in Philadelphia, in the Philadelphia area at these two incredible congregations. Thank you for letting us share our information and you sharing your evening with us.
Before we get started, I want to remind everybody that there will be a question and answer opportunity at the end of this program. If you do have questions as we go along, please feel free to put them in the Q&A box. We'll be checking that periodically as we go through. And with that, I'd like to ask our first question. Dr. Brem, you are a trailblazer in early detection of breast cancer, even being called a cancer detective by Dr. Oz. Can you tell us your story and how you chose radiology and breast imaging as the way to make a difference in women's lives?
Of course, it'd be my pleasure. So every single one of us, I don't have the privilege of seeing all of you, but every single one of us has been touched by breast cancer. My journey started at the age of 12 when my beautiful mother disappeared for some time, and only months later did we learn that she, at the age of 33, had breast cancer. We were told that she had 6 months to live, and the end of the story is that she lived 44 more years to see grandchildren and great-grandchildren. But the story was that it was early detection that helped her survive, even though she wasn't given great odds. And as a 12-year-old, I decided that I was going to do everything I could to stop other young girls from having the tragedies that our family did. And so I went on to medical school. I was at Columbia, and it was a very exciting time when I was in medical school because mammography was just starting to bear its fruits and showed us that women who were screened died a lot less often from breast cancer, that mammography really saved lives. And so I decided to pursue that, to really try to impact breast cancer and to impact families like so many of ours that are impacted by breast cancer. But the story actually continues because when I was the director of breast imaging, I was charged with finding ultrasound equipment. And when I was 37 and Andrea was 12, not only did I find the ultrasound equipment that I needed, but while I was scanning myself after a day of seeing patients, I found my own breast cancer. And like Elisa, I chose to have bilateral mastectomies and reconstruction. I had chemotherapy, but that really gave me a lot of insights. It's the silver lining that I could now understand not only what a breast cancer physician goes through, but what a breast cancer patient goes through. And here I am many years later, healthy and grateful that I can have the impact to help other women with breast cancer.
Thank you so much for that. You talk a lot about risk-based screening and personalized screening. What does that really mean, and what do you most want women to know before speaking to their doctors about breast care?
Well, I'm very glad that you asked that question. And before we get to risk-based screening, I really want to spend just a few minutes talking about mammography screening. Mammography is the basis of all screening. It's the starting point. Now, you've heard so much in the media about when you should get screened. Should I start at 40 and go every year? Or like the USPSTF said, start at 50 and get screened every other year. Or even the American Cancer Society says, start between 40 and 50, and then every year between 45 to 55 and every 1 to 2 years afterwards. So much noise, so much differing information. But what everybody agrees on, and what I want everybody here to know, is if you get your screening mammogram starting at the age of 40 every year, that will minimize women's death from breast cancer. So you might say, really, how can that be that other people, other organizations, other reputable institutions recommend different things? So if you look at the USPSTF, they say, well, if you have a mammogram every year starting at 40, we will maintain the 40% reduction in the death rate for breast cancer we've achieved in the past 2 decades. And you heard that right. Almost half of the women who used to die from breast cancer don't, because of both screening and therapy. So the USPSTF says, you know, if we do it less frequently and start later, we will still maintain 88% of the mortality reduction. That means 12% more women will die of breast cancer. Raise your hand if you or anyone you love should be one of those people. And I know no one is raising their hand. And so you say, why are they doing that? And the answer is something called the harms of mammography. The biggest harm of mammography is anxiety. And this absolutely drives me crazy because, first of all, yes, if you have a mammogram and you get called back for another imaging study, or if you even need a biopsy, does it cause anxiety? Yes. But we've learned that it's transient. There's no permanent anxiety. And more than that, it makes me feel like we live in the Middle Ages. Shouldn't empowered, educated women make the decision to decide whether they should go for mammography every year and optimize their chances of finding early curable breast cancer? So the one message that's really important tonight is, like the video said, start at 40 every year, not every other year, not at 45, not at 50. That way we can save more lives, more American women's lives from breast cancer. But we have other things. It's not a one way of screening. So women who have other risk factors need additional screening. And so the next thing we need to talk about is breast density. If you have dense breast tissue, you need additional screening. The only way you can find out if you have dense tissue is through a mammogram. And the reason that that's really critical is because breast cancer is white and breast tissue is white. And if you have a dense mammogram, those cancers can be hiding in that white dense tissue, like a cloud, a specific cloud on a cloud-filled sky. So because of that, mammography is less effective. Although mammography finds 85% of breast cancers in women with dense breasts, more than a third of breast cancers are not mammographically visible. And to add to that, women who have dense tissue have a substantially increased risk of developing breast cancer, 4 to 6 times higher risk of developing breast cancer. So we have this perfect storm. And we know that with additional screening like ultrasound or MRI, we can find these hidden cancers. And these are really important cancers. And what I mean by that is they're small, invasive, so potentially killer, but early node negative breast cancer. Now, in Pennsylvania, you just passed a law called Senate Bill 595 that you've now joined the District of Columbia and 7 other places in the country that require insurance companies to cover these additional screenings. And I'm very proud of the Brem Foundation for writing the bill in DC and being the 6th place in the country to pass a bill that requires insurance coverage for these screenings in women with dense breasts. And there are other risk factors. You'll hear a lot about family history and genetics, a very high risk factor. So people who have these genetic mutations that Liz Stark will talk about should have MRI every year so we can find the earliest breast cancer. And so the way to think about it is, if I have a non-dense breasts, no other risk factor except the number 1 risk factor, like you heard, that is being a woman, a mammogram is enough. If I have dense breasts, you must advocate for yourself and insist on getting screening examinations with ultrasound. And in fact, in Pennsylvania, you now have a bill that covers that. And if you're at higher risk, then MRI or molecular breast imaging will help us find even smaller cancers. And you may ask, why doesn't everybody get an MRI? And the answer is that it requires an injection. There's an injection of a compound that's been shown to collect in the brain. We don't know that it does anything nefarious, but it does. And so we know that the best way to approach this is regular, no dense breast mammogram, dense breasts, mammogram plus ultrasound, and higher risk than that, mammogram and MRI.
Thank you. Thank you so much for that. If you could just help women break down what are risk factors. So you talked about breast density. We touched a little on family history, but I think it would be great to just be able to talk about those risk factors, because as we all know, breast cancer is really well marketed, but oftentimes we don't fully understand what makes one woman more or less likely to get breast cancer.
Great question. Thank you for asking. So there are risk factors that we can change and risk factors we can't change. So we talked about family history briefly. You'll hear a lot more about that. Women who have a genetic mutation, like Elisa talked to you about, have a very high risk of developing breast cancer. It depends on which mutation. The most common are BRCA1 and 2, and they have about an 80% risk of developing breast cancer. Liz Stark will tell us much more about that. The older you get, the higher your risk of breast cancer. So it just doesn't change. So you can't change your age, but you need to know as you get older, then your risk increases. If you've had a biopsy that shows that your cells are not completely normal, something we call atypia, that also increases your risk of breast cancer. And then some things you can change: obesity, alcohol intake, healthy balanced diet, and of course, hormone replacement therapy. And I have this discussion with my patients all the time. Taking hormone replacement therapy increases your risk of breast cancer. Even if they tell you it's bioequivalent, biosimilar, if you take exogenous hormones, hormone replacement therapy, your risk of breast cancer will increase. So some things, and then of course, Ashkenazi Jews and other populations have much higher likelihood of developing, of having these genetic mutations. So again, I don't want to talk about it, but in the general population, it's about 1 in 400. Among the Ashkenazi Jewish population, it's 1 in 40. So there are more than 40 women on this event this evening. You've already seen 1, 2, 3 who are BRCA positive or have other mutations. But even if that weren't the case in a group of 40 women, Ashkenazi Jews, you can expect at least one of them to have this mutation.
Thank you so much for explaining that. You also already mentioned briefly the correlated screening options. I just think it's worth mentioning one more time that a mammogram is often not enough, especially for a higher risk group of people like the one likely with us tonight. So please don't forget that, you know, to really maximize your chances, you need to have more than just a mammogram. It's an easier sound.
Can I just talk about a 3D mammogram for a second?
Sure.
Sure, thanks.
And you should note that Pennsylvania is one of the few states where 3D mammograms are fully covered for screening purposes.
So a 3D mammogram, a picture is a 2D image of a 3D object, whether it's a person or a breast. And in previous, or in some places still using 2D mammography, it takes a 3D object and takes a 2D image of it. But with 3D mammography, we take very thin slices through the breast and we look at a video of each slice. The reason that's so important is because it takes away some of the confounding factors of dense breast tissue, because we can sort of unpeel each slice individually and sometimes see the things that are hiding underneath. Many places have 3D mammograms, and you should advocate and go to a place that has 3D mammograms. It is not, there's no downside, there's only upside. And which brings me to one more thing about breast cancer and self-advocacy. We are empowered, strong women, and we need to advocate for ourselves. When it comes, we can't change some of our risk factors, we can change some of our risk factors, but what we can do is advocate for ourselves. To go to a place where someone is interpreting predominantly breast imaging studies for their expertise, to go to some place that has 3D mammography. And if you feel that something is wrong with you and you go to your doctor and they say it's nothing, then go seek another doctor, because you have to advocate for yourself. Nobody knows you as well as you know you. And sadly, I can't tell you how many times I've had women in my office who have been going to their doctor for a long time saying something's wrong, and they are assured that everything is fine. They're too young to have breast cancer. They don't have any family history, any other reason. And in fact, they then do have breast cancer. So it's very important to advocate for yourself if you feel that something is wrong.
Thank you so much. Shifting gears to something that we all hear probably too much about, could you talk a little bit about breast cancer and screening in the age of COVID?
Yes, I would very much like to talk about that. In March and April, there was almost a 90% reduction in the number of women going for screening. We couldn't screen. We were learning about COVID. We didn't have PPE. We didn't have enough blood. Our hospital beds were filled. And so not only were we not screening, but we were doing the unthinkable. There were women who were diagnosed with breast cancer whose treatments were delayed. But that is behind us now. And we have learned how to safely see our patients with deep cleaning, with social distancing, with screening for COVID. And we now also know that we're seeing less breast cancers, and the cancers we're seeing are larger. The American Cancer Society last week said that 10,000 additional people will lose their lives this decade because of the reduction in screening for cancer. And breast cancer screening is first among them. So what does that mean? Don't skip your mammogram this year. Breast centers have learned how to safely see our patients, how to do what's necessary to maintain the safety, and don't lose the opportunity because of COVID. One more tragic consequence of COVID would be to lose a life as a result of delayed screening and the later breast cancer detection. And remember that early detection is better survival, but it's also a much less intense therapy journey. So we have to find early breast cancers because we want to optimize our survival, but we also want to minimize our therapies. And the way to do that is with early detection.
Thank you so much. I will say, if anybody does feel uncomfortable before they go, you can always call. You can always talk to the center itself about what their policies are to make sure that you feel comfortable. And generally, centers are going to be very accommodating because they're trying so hard to get people in. Thank you very much, Dr. Brem, for that insight. Before we move on to Liz, is there anything else that you want to tell the wonderful women who are with us here tonight?
Get your screening. Even in the time of COVID, you will save a life, and it's a critically important thing to do. On the Brem Foundation, we have a pledge to get your mammogram, to not miss your screening this year, and take that pledge and go for your screening.
We'll send it around in the chat so everybody can see it if they'd like to. With that, I am honored to introduce Liz Stark. Elizabeth Stark is a licensed and certified genetic counselor who focuses on helping families with inherited cancer syndromes. Liz has a special interest in making sure that testing is accessible and affordable for anyone who wants this important health information. I have had the honor and privilege of working with Liz now for a number of years, and I can assure you that there is no one more qualified and no one more comforting than Liz. So you are very lucky to have her here tonight. She does also have 3 kids, one of whom is still a newborn at home. So her evening time is precious, and I'm so glad that she was able to be here with us tonight. Hi, Liz.
Hi, Andrea. Thanks for inviting me. It's really nice to be able to share this time and to be able to speak to people, even in the time of COVID, about a topic that I know is really near and dear to all of our hearts. So thank you for the opportunity.
For sure. So Liz, as you know, we're with a group of Jewish women tonight. Can you talk to us a little bit about how genetics plays a role in breast screening, particularly for the Ashkenazi Jewish population?
Yeah, absolutely. So I love the message of the video because it really starts off with every woman has a risk for breast cancer. And it's so important that every woman be screened for breast cancer. But where I come in is that we know some people need to be screened younger and they need to be screened differently. And so, like Dr. Brem mentioned, we know that the proportion of Ashkenazi Jewish women who have a BRCA mutation is higher than other ethnic groups. Every group can have a BRCA mutation, but that risk is 1 in 40 in the Ashkenazi Jewish community. In addition, what that tells me is that these women don't need to start at 40, they need to start at 25. And the only way you can know that sort of information is either by talking to your doctor about your family history of cancer or by doing a genetic test. Sometimes it's helpful to know if someone has a genetic mutation because we're in this era of personalized medicine. And so my job is to not only look at the breast cancer risk, but also to look at the whole body and say, are there risks of other cancers that we need to be concerned about as well? So we're very good at catching and treating breast cancer. I'm also concerned about catching and treating some other cancers that are not as easily treatable. And so knowing your genetic background can really help us personalize and tailor a plan for everyone. In addition, in the Ashkenazi Jewish community, we also know there's a founder mutation that slightly increases risk for colon cancer. And so that's another one where we can start screening younger and go more often and really try and make sure that we're protecting people.
Thank you so much, Liz. If someone already knows that there's breast cancer in her family or another cancer, should she think about genetic testing? How should she go about beginning that process?
Yeah, that's a great question. And it's one we hear a lot. People come in and they'd be like, I already know there's breast cancer. You're not going to change that. And they're right. I'm not going to change that. But we always want to try and start testing with the person who's had cancer if they're still with us, because that's going to give us a more clear-cut yes or no of who in the rest of the family could be impacted. So if a woman has lost her mom at a young age to breast cancer, who maybe never had an opportunity to test, even if she's negative, we're still going to have to be more careful, and we're still going to have to screen more regularly and potentially using some of the other modalities that Dr. Brem mentioned, like the MRIs, the ultrasounds, because we just don't know what caused that cancer. Whereas if someone screens positive, someone has a mutation and her daughter doesn't inherit it, we're not going to be as worried. We still want her to get a mammogram at 40 and to go every year because she still has the risks of being a woman, but she may not need to be doing the every 6 months, starting at 25, using the extra screening modalities. So it's really, really helpful if the woman who's had cancer can start with the testing. In addition,
go ahead.
Yeah, I was going to say, in addition, we are sometimes always worried about other cancers. And so I don't want a woman to, beat breast cancer only to be faced with another cancer that could have been preventable or caught more early if we'd just been screening a little bit more aggressively for other body parts.
Right, of course. Can you talk a little bit about whether these genes are passed only from a male or a female, or how they can be passed from either?
Yeah, absolutely. So the genes that we're primarily looking at are called tumor suppressor genes, and that just means that they're protecting us from cancer. They come in pairs, so you get one copy from your mom, one copy from your dad. And so when we say that someone's BRCA positive or has BRCA, we know everybody has 2 copies of BRCA, but some people have a broken copy. So it's like they're missing their backup set. And so because everybody has a copy, one from their mom, one from their dad, dads can pass on mutations just as easily as moms. And that's what we find is sometimes a mutation can almost look like it's hiding. They don't skip generations or anything like that. But if it's passed down from grandpa to dad to daughter, sometimes it can look like that because dads have very little breast tissue and no ovaries at all. So, sometimes it's just, we have to look at families a little bit differently when we're trying to figure out what's the likelihood that there's a mutation being passed down.
Thank you so much for that. If a family member was diagnosed and did testing when she was diagnosed, but it was a number of years ago, does she still need to consider testing? And does this matter if it's a first-degree relative or a second-degree relative? And it might be helpful if you define what those two things are.
Yeah, absolutely. So we've had huge advances in genetics as far as determining what's caused cancer. We've known about BRCA1 and 2 for a long time now, since the early 90s. We're really good at understanding how to find those mutations and what to do about them, but that's all we were looking at for a really long time. There are actually a handful of genes that can really raise your risk for breast cancer, some as high as BRCA or even higher. And so it's important that we look at all of those different genes. If a woman has a family history of breast cancer and someone tested negative, did not have a BRCA mutation, that doesn't necessarily mean they don't have another mutation that we can now find with today's technology. In addition, the actual test has changed. So I kind of think of this as like a computer program. We used to just do a spell check on BRCA. But now we look to see if paragraphs switched places or if whole paragraphs are deleted. A spell check isn't going to find that sort of change. So the testing for today is a little bit more sophisticated, a little bit more thorough to not only look at the BRCA genes, but a whole handful of other genes. So if you have a first or second degree relative, so a first degree relative being a sister, a mom, a second degree relative being a grandparent, an aunt, then I think it's a good idea to talk to them if they've had testing, if they're still with us, if they're willing to do update testing, which just means they're going to look at some more genes. And if they aren't with us, considering testing yourself with one of the larger panels that we're doing now.
Thank you so much. The last question before we talk a little bit more about other topics is how does genetic testing impact health insurance, if at all?
That's a great question. So we have a law that came into place in 2008 called the Genetic Information Non-Discrimination Act, and that prohibits your health insurance from using this information against you. They can't raise your rates. They can't drop your coverage. They can't call it pre-existing. Your health insurance is absolutely covered. And it's really important for your health insurance to know about a mutation like BRCA, because that's how they're going to cover the MRIs. No surgeon is going to talk to you about a prophylactic mastectomy or having your ovaries removed if you don't have a BRCA or some other genetic report showing the indication why. And so we want those things to be covered, and we know there's great protections for health insurance. The gray area is life insurance, disability insurance, and long-term care. The good news is we don't have any reports of people being denied these insurances today based on their genetic test results. If you go and try and get a policy, they're not asking those questions. The gray area comes in that it's not protected under GINA, that law I was just mentioning. So there's nothing to stop them from doing it in the future. So I definitely recommend everyone get insurance, pay your premiums, because they can't go back once you've got it.
That's great. Thank you so much. Liz, before we move on, is there anything else that you would like for everybody to know here tonight about genetic testing, particularly as it relates to breast cancer and screening and risk factors?
Yeah, I'd like people to know that this is information that's been in your body from the day you were born. It's not changing, it's not coming or going, but what it does have is the power to help you make some decisions that maybe you're feeling scared because your family history has a bunch of cancer, and these are hard conversations to have. This testing doesn't change it, but it may give you the tools to change the narrative for not only your generation, but generations to come. So I really want to encourage you to reach out. I'm available. I'm happy to talk to people offline if they have any questions about it or want some more specific information about their families. But really, we're here to help. There's a whole army of us that are behind you, hoping we can get you the most information we can.
Thank you so much, Liz. With that, I'd like to take a couple of minutes and just talk for a little bit about what the Brem Foundation actually does. As you know, the Brem Foundation is a breast cancer nonprofit. We maximize every woman's chances of finding early curable breast cancer through education, access, and physician training. What that means is a couple of things. First, we are fully on the pre-diagnosis side. Breast cancer is a really well-marketed disease. So you'd be hard-pressed to find anyone in the United States that doesn't recognize the pink ribbon, doesn't know what breast cancer is, doesn't even know that, almost everybody knows that you need a mammogram. But the problem with that marketing and that publicity is that people really don't know what they need to know when it comes to risk factors, screening options, and self-advocacy. And that's where the Brem Foundation comes in. As you may know, breast cancer, when caught early, is 95% curable, and some stats say even more than that. But in its latest stages, that drops to about 22%. It's a big difference. And we have the technologies and the tools to find almost every breast cancer early. But women need to be armed with the knowledge and the tools to know what to ask, what the right questions are, and that's exactly what the Brem Foundation does. So you all are actually the recipients tonight of our first primary pillar, which is that education. We also know, though, that education is only as good as the tests that a woman can access. So if you have all this education, you're armed with the right knowledge, you know your risk factors, your screening options, how to self-advocate, but you can't get or can't afford a test, you're still out of luck. So the Brehm Foundation decided that we were going to try to help solve that problem as well by starting 2 access programs, the B Fund and Wheels for Women. The B Fund is a fund, like its name, that pays for lower income women's diagnostic tests when they can't afford them. So a screening test is a test for a woman that has no clinical symptoms and is truly a screen. However, a screening test does not provide a complete diagnosis of breast cancer if there is an abnormality. If a screening test picks up an abnormality, that woman then needs a diagnostic test. Well, diagnostic tests, unlike screening mammography, are not free. And oftentimes a woman in need will go and get a screening mammogram and then be told she has an abnormality and she needs a diagnostic test, but she can't afford it. And so the Brehm Foundation partners with nonprofits on the ground in lower income communities to pay for those diagnostic tests after an abnormal screen. Through the B Fund, women will get their tests within 2 weeks of an abnormal mammogram and either be able to start on a treatment plan as early as possible or have the peace of mind that her abnormality was not a breast cancer. We also recognize, however, that the barriers to care are not just the test itself, but also other obstacles like childcare, like time off of work, like transportation. And while we would love to have the money to tackle all of them, we don't. And so we decided to tackle transportation. We partnered with Lyft to create Wheels for Women, which is the first and only cost-free ride-sharing program for lower-income women in the United States that's exclusively dedicated to getting them to and from breast care appointments. We started this program in May of 2019, and we've done almost 500 rides to date. The need was way more than we could have ever expected, and this program is serving primarily immigrants and women of color. So we're proud that we are, part of the solution for the transportation challenges of getting breast care. Finally, the Brehm Foundation has a robust physician training program. We support the only breast imaging fellowship in the country that also has a mandatory community service program. So my mom, Dr. Brehm, trains full-fledged radiologists to specialize in breast imaging. And the Brehm Foundation helps train these radiologists in how to do public health outreach, education, with the hope that we're inculcating a lifelong commitment to outreach, because we know that once the patient's in the office, half the battle has been won. And finally, while it's not a core pillar of ours, we run a program called Rebra. Rebra is a bra donation and collection program whereby we collect women's bras who no longer need them. We have a partnership with a dry cleaner who dry cleans the bras. We clip them with breast health information in English and in Spanish, along with resources for women to be able to find breast centers in their area. We are very proud of this program. And if you are interested, we can try to help arrange something, although after COVID, collecting anything physical has presented even more challenges than we thought. And so in a nutshell, that's who we are. That's what we do. We are a scrappy, loving, and wonderful team of 4. COVID has presented a whole new set of challenges to make sure that women get their breast care. So if you have the inclination tonight to make a donation, we would be most grateful. Every dollar counts. Your support really, really matters as we try to find the women who've been especially hurt by COVID financially, emotionally, and physically, and help them get the supports they need to be able to get the breast care they deserve. We have a link in the chat box right now to a donation spot, and we hope that you are able to contribute and spread the word. But really the message I want to leave you with tonight is that no matter what you do, don't skip your screening because of COVID, and tell all the women you love to do the same. With that, I would love to open the floor for questions and answers. We see some great questions already coming in. Don't be shy. I won't call you out by name, but I'd love to bring back Dr. Brehm and Liz so that we can all have a discussion about whatever is on your mind tonight.
Thank you.
Liz. Hi. So the first question came in and reads, if one is diagnosed premenopausally like you and your mother were, wouldn't you advise that your daughter start mammography earlier than age 40, like at age 35? So before we answer this question, just to be sure that everybody has the story straight, I never had breast cancer. I had prophylactic mastectomies at age 30 because my grandmother had breast cancer at 33 and my mother at 37. And so I was fortunate enough to know that I was BRCA positive when I was 22. I had prophylactic mastectomies, but never did get diagnosed with breast cancer. Nonetheless, this is a great question, and I'd like to throw it out to Liz and Dr. Brown.
So that is an excellent question. There are certain populations of women, particularly those who have known genetic mutations or untested family members, first-degree relatives of women with genetic mutations. So, and if you have a known genetic mutation, screening should start at 30. If you have a first-degree relative who's had breast cancer, screening should start 5 to 10 years earlier than the age at which that relative developed breast cancer. And it should be noted that women who do have genetic mutations should have screening both with mammography and with MRIs every year.
Thank you so much. The next question asks, does use of estrogen or Premarin increase the risk of breast cancer?
So estrogen and Premarin, both hormone replacement therapies, have hormones. The question is, some of the end organ hormone replacement, like some of the rings, the vaginal rings, only give estrogen locally to the end organ in the vagina. But if there is an increase in blood estrogen, then yes, the risk increases. So you need to not ask your OBGYN, does this increase the risk of breast cancer? But what you need to ask is, if you test my blood, will my estrogen be higher or my progesterone be higher as a result of this? And then the answer is yes. And I have to say that, a lot of what we deal with, and, Liz can answer this as well. There are a lot of things that we have to deal with and decisions that we make, and they're all good decisions, right? There's some women who have genetic mutations who opt to undergo, surveillance every year, screening every year. And there are those who opt to have prophylactic mastectomies. And those are both really good options. It's fundamentally different. One tries to prevent ever having breast cancer, and one wants to find it while it's early. But nonetheless, we have to understand that these are very personal decisions, and they're all okay. But, and the same thing is true of hormone replacement. There's some women who just can't get through a day without it. It's a calculated risk. But if someone, keeps asking, the answer is yes. If you have hormone replacement, your risk of breast cancer will go up. That may be an acceptable risk to some women, not an acceptable risk to others, but the answer is yes, the risk does go up.
Thank you so much. This next question is for Liz and reads, if my mother is BRCA negative, does that lower my risk, or would my father also have to be tested?
It does. So it does lower your risk by about 50%, but you definitely inherited a BRCA gene from your father as well. There are some who say, and I happen to agree with them, that all Ashkenazi Jewish women should consider BRCA testing at age 30, because we know that the prevalence is high enough that we're going to catch some women who may not have known about a mutation running in their family. They actually did a study in Israel, and they found that of those people who had no family history, no known indicators that there was anything going on in their family, if they tested positive, their risk of breast cancer, instead of being 80-85%, was 70%. So tell me if you would be okay with a 70% chance. So it's one of those things where we really think women should know what their status is around age 30.
Thank you. Also, Liz, I just want to mention that the Brem Foundation also has a great relationship with Color. Mm-hmm. And we have a discount code that if you do want to do the comprehensive panel, I believe, Liz, correct me if I'm wrong, but it's 36 genetic mutations that it tests for. Is that right?
So this is a 30 gene. So when you go to color.com and you order the test, it's a saliva kit that will get mailed directly to your house, which is convenient in the times of COVID, certainly. And it's a 30 gene hereditary cancer panel. There's also a 30 gene heart health test and a medication response test. It's usually $250. But yes, because of our great relationship, we want to offer everyone $50 off of that using the BREM code.
And we put in the link in the chat box if you're interested. Also, you should know that a genetic counselor, they, as you can see, Liz is here, but they are genetic counselors and physicians working at Color. So it's not just a spit in the tube and nobody looks at it or sees you again. It's actually been a really, really great relationship and a really nice way for people to find out whether or not they have these genes. So thanks, Liz. Okay, the next question is also for Liz. If you had a BRCA test 20 years ago and it was negative, do you need another one with updated technology?
So I think it would be a good idea to consider. If you had the BRCA test 20 years ago because your mom was positive, then you're still going to be negative. That's still what we call a true negative. But if it was because you had breast cancer, you had a family history of cancer, that's when all of these other things may come into play. We also know about 5% of our families who have a mutation have more than one. It is possible to have BRCA and another mutation, in which case sometimes we're missing people. So I think if it was 20 years ago, it's probably a good time to think about doing another one. Not because the information looked at then is wrong, there's just a lot more information to look at in addition.
Right. Thank you so much. We have a question now for Dr. Brem. What are your thoughts on getting yearly sonograms? Does 3D mammography replace the need for sonograms?
That is a great question. And the answer is a resounding no, that 3D mammography does not replace ultrasound. They are complementary. And if you have dense breasts, you should have both of them every year. Studies have shown that, when we first started doing screening ultrasound, we said, well, if we do it on year 1, are we still going to find cancers in year 2? And the answer is yes, year 2, year 3, year 4. And that's a great question. Ultrasound does not preclude the need for mammograms because there are signs of cancer that we see on a mammogram that we don't see on an ultrasound. But those hidden invasive cancers that we don't see on mammography, we do see on ultrasound because the cancer is dark on ultrasound and breast tissue is bright. So that contrast is optimized to find cancers in women with dense breasts. So you must get both every year. Thank you for asking that.
Thank you. We have a question of somebody who said, what if your dad had early detected breast cancer and survived after surgery, and he does not have BRCA, and maternal grandmother also had breast cancer, unknown BRCA, and this person has dense breast tissue? What should she do?
Well, if dad only had BRCA testing, he's also should consider additional genes. There are other genes that raise the risk for male breast cancer outside of BRCA2. So I would first have him do update testing. And then for mom's side, you can still consider testing if you don't know what the status is of the mutations on that side of the family. And I'll throw it to Dr. Brem for the recommendations.
Well, I think that, if you are untested, you are then certainly a family member of breast cancer on both sides with the father. So we would, in our institution, we would certainly encourage MRI screening in this population. Remember that we recommend screening MRI annually for people who either have a genetic mutation or have a strong family history, because every year, Liz and her colleagues are finding more and more mutations. So if we had this next year, we would have more mutations, or last year, we've got more now. So, we haven't defined all the mutations. And if you are untested and have a strong family history with multiple first degree relatives, particularly a father or multiple second degree relatives, getting screening MRI sounds very reasonable.
Thank you so much. So somebody asked, I was tested by 23andMe for BRCA 1 and 2. Is this as reliable as a medical test? What do you think about 23andMe?
So 23andMe is very accurate for the 3 Ashkenazi Jewish founder mutations. And that's what makes the difference between the 1 in 400 to the 1 in 40. But you have to keep in mind that an Ashkenazi Jewish woman can have a mutation other places in the gene. So we think of it like BRCA being a book. You had 3 words of that book read, and it's great news that those words were all looking how we would expect them to, but you can have mutations in a lot of other places. So I would recommend comprehensive testing. We don't even order what we call multi-site 3 anymore because we found so many other mutations in other places.
Thank you so much. I will start out answering the next one, and then we can all actually chime in. Somebody asks, is there going to be a time when all insurance companies cover ultrasound? Now they are considered a diagnostic test, not a screening test, ? Some insurance companies won't cover diagnostic testing, especially if the mammogram comes back dense L1. So what I would say to you, and one of the reasons I want to answer this is because I am actively part of the effort at the Brem Foundation to try to get more states to pass legislation that would mandate insurance coverage. Right now, 11 states and the District of Columbia do have mandatory insurance coverage. Now, that's not all the same. Some states cover MRIs, some states cover 3D, some states cover ultrasound, but there is some form of mandatory insurance coverage in 11 states plus DC. So I assume most of you are in Pennsylvania. Pennsylvania actually was our flagship state this year because you all just passed a bill. It was Senate Bill 595. Now I don't know what they're calling it, but it is law. And this bill says that for women who have extremely dense tissue and or are at higher risk, ultrasounds and MRIs have mandatory coverage by insurance companies. So the bill actually doesn't explicitly say what this means for cost sharing, whether there is a copay or there are other out-of-pocket costs, but it does mean that you are not fully paying out of pocket for any of these tests, and they are considered screening tests for higher risk women. I would encourage all of you to join the effort if you do live in a state that does not have mandatory insurance coverage at this point, because this will be a real avenue to give more women access to these tests, because for certain women, they are critically important at the screening level as well as the diagnostic level, but we would have fewer later stage diagnoses if more women are properly screened based on their risk factors, and coverage is a key component to that. Do either of you want to add anything to that?
I'd like to add, I'd like to explain a little bit about coverage for health and for screening. Mammography, according to the ACA, is covered with no deductible and no copay. So if you go get a screening mammogram, it should be free to you. If you go get a diagnostic mammogram, there is a deductible and a copay. And there is a code for screening ultrasound. So in some states, it can be fully reimbursed. But that is still, as you heard from Andrea, and see in your own state, a work in progress. But understand that a screening mammogram should be free. If you have a diagnostic referral, it will not be. And we hope that there will be full coverage. There is now a bill that requires women to be told what their density is, a federal bill, but it does not cover additional screening.
That bill is not enacted yet at the federal level, but
Right.
Pennsylvania does have a density informed law that's a very, very good law. So every mammogram report in Pennsylvania does have information about your breast density. Okay, wow, there's a lot of stuff coming in. Could you please explain and elaborate about the stages of breast density?
Yes, thank you. So breast density, there are 4 stages or 4 types, A, B, C, and D. Women who have dense breasts have C and D. And in fact, in your state, in Pennsylvania, women with D are covered by Senate Bill 525, and women with C density are covered if they have one more risk factor. But basically, it's 25%, 50%, 75%, and up to 90 or 100%. It's not quite that clear, but that's generally the way you think about it. And again, you can only tell about your breast density from a mammogram.
Thank you. To add on to that, there's a question that asks, can the density of your breast change with time?
That is a great question. Your breast density does change with time. 70% of women in their 40s have dense breast tissue. As you age, your density goes down. And in fact, when we did use a lot of hormone replacement therapy, when I first started out in breast imaging, you could actually see the breast density change based on the dose of hormone replacement therapy. As you get older, your density decreases. However, even 30% of women in their 70s have dense breast tissue. So there is no age where you can't have dense breast tissue, but your density does change with time and with menopausal status. Postmenopausal women have lower density than premenopausal women.
We're going to take 2 more questions, and then I welcome anybody else who has more questions to either email me directly at andrea@bremfoundation.org, or you can email info@bremfoundation.org. We do actually check that, just in the interest of time and letting people have their evenings. So let me ask these next 2 questions, and then we'll wrap up. It seems that breast cancer is much more prevalent than when I was younger. If that's accurate, what environmental factors do you think contribute to this? Or I would expand on that. This is Andrea talking, and say, what factors, environmental or otherwise, may contribute to this?
The American Cancer Society definitely ascribes a very significant proportion of breast cancer to carcinogens. There are some estimates that say 30 to 40% of breast cancer are environmentally induced. However, we really don't know exactly what those are. So you read a lot of information about, whether fragrance and detergents and dryer, all kinds of things, M&Ms, food coloring. Well, it's good to avoid those, but the data is not compelling about them. We do know that there are certainly certain carcinogens in water, in the air, very hard to impact without impacting pollution overall air quality. But there are many carcinogens that we are often exposed to. And that's one of the reasons that we need these tumor suppressor genes, because our bodies not infrequently have a misdivision that causes a cancer cell, but there's this cleanup mechanism that Liz talked about, and those are called tumor suppressor genes. They basically clean up the cancers that might form in your body, and when one isn't cleaned up, that's when we get a cancer.
Thank you very much. And our last question says, my mom had ovarian cancer and I was tested for BRCA and was negative. Am I at any higher risk for breast cancer, and what screening should I do?
So I would encourage you, again, if you're only tested for BRCA, to look at some additional testing. There are actually 9 different genes that we're now strongly associated with ovarian cancer risk. And the National Comprehensive Cancer Network just came out saying they feel like there's a strong correlation with triple negative breast cancer in many of those genes. So I think it would be an important idea to do some additional testing. And then if there's nothing there, then falling back on the family history. I mean, certainly every woman should be getting a mammogram at 40. So if you're in that category, you should be getting a mammogram. But anything outside of that, if you're negative on the panel, should probably be based on family history.
I would just say that getting advice, seeing a genetic counselor, can be extremely helpful and extremely informative. We send our patients to genetic counselors because we can skim the very top of it, but they're the ones with the depth of knowledge about genetic mutations, and they will take comprehensive histories to understand what other mutations you might be at risk of. So, one thing is to get tested, the other is to have a discussion with a genetic counselor. It's extremely helpful.
Thank you so much. I'd love to welcome back on Wendy and Amy and Elisa to say goodbye. And as I do, I want to remind people to take the pledge. Really, if there's anything we can hammer home, it's not to skip this year. Don't be nervous about so many different things. It's hard for me to say don't be nervous this year, but try to take that pledge and send it to people who you love. With that, I want to say thank you. I want to say thank you to all of our panelists. I thought this was a very engaging discussion with a really remarkable audience. And please stay in touch with us. We're here for you and with you. And we wish you a safe and wonderful evening and rest of the year. Thank you all so much.
Thank you. Thanks for being here. Thank you to BTBJ, to the Sisterhood, and to Ormi for joining us this evening. I know there's a lot of people from other communities who jumped on and participated. So I just want to say thank you for joining us tonight. I hope this was helpful. Thank you.
Thank you all for joining us.
Bye. Thank you.